Welcome to the Deep Dive, the place where we sift through the sources, find the biggest insights, and make sure you're walking away with knowledge that sticks.
Today, we are really getting into something important.
We are. We're focusing on a piece of medical technology that is, well, it's everywhere. The computed tomography scan, or CT.
An indispensable tool, for
Yeah.
sure. But it comes with a catch.
And that catch is ionizing radiation.
Exactly. And that tension, between life-saving diagnostics and a known risk, that's what we're exploring. CTs are absolutely critical, but we have to talk about the long-term consequences.
Right, so the core question for this deep dive is, how big is that long-term risk?
Specifically for the U.S. population, we're basing this all on a major risk model study that looked at just 1 year, 2023, and projected the lifetime cancer risk from those scans.
And the scale here is, it's kind of hard to wrap your head around.
It really is. To set the scene for you,
No.
in 2023 alone, in the U.S., we are talking about roughly 93 million CT examinations.
93 million.
And those were on about 62 million individual patients. That level of exposure is our starting point.
So our mission today is clear. We need to translate that massive volume into a real public health projection.
What's the estimated future cancer burden? Where is the risk concentrated?
And at the end of the day, what does this data mean we should be thinking about for the future?
We're going to connect the dots between that 93 million and the eventual toll on public health.
Okay, let's jump straight in. What is the headline number?
The anchor number, right.
Based on that 2023 data, the model projects an estimated 103,000 radiation-induced cancers over the lifetime of those patients.
That is the big figure, and it's a pretty solid one. It comes with a tight 90% uncertainty limit, placing the range between about 96,000 and 110,000.
So we're reliably talking about over 100,000 future cancers from just 1 year of CTs.
The scale is fixed, even if the exact number might shift a tiny bit.
Okay, so I think the first question anyone listening is going to have is, how do they even get to a number like that? How robust is this projection?
It's a great question. You can't just, multiply the dose by some simple factor.
Right.
It's a highly complex framework. This estimate used sophisticated software from the National Cancer Institute, and it's built on the BEIR7 models.
The biological effects of ionizing radiation 7 models?
That's the one. And for anyone who doesn't know, BER7 is basically the gold standard for this kind of risk projection.
It's the authoritative source.
Precisely. These models draw on decades of data, most notably from the Japanese atomic bomb survivors. It gives us a linear, no-threshold model.
Meaning any dose, no matter how small, is assumed to carry some risk.
Exactly. Which makes the projections very credible and often statistically conservative.
Okay, that gives the model credibility. But how do they apply that to 93 million real-world exams? That feels like a huge leap.
They bridged that gap using real-world dose data. They took information from the University of California, San Francisco International CT Dose Registry.
So not theoretical doses, but what machines are actually putting out.
Yes. High-quality data on actual radiation output in modern clinical practice.
So they took a very detailed sample of how the scans are being done.
Exactly. And they scaled that frequency and dose profile onto the total 2023 U.S. population counts. So it's based on what's actually being delivered in clinics across the country.
That makes sense. It's a powerful way to translate real data into a national projection. So who are these patients? Let's get into the demographics.
Okay, so out of the 61.5 million patients, the vast majority were adults.
I'd imagine so.
Almost 59 million people. That's 95.8% of the total.
And children.
Children and adolescents made up the remaining 4.2%, so about 2.57 million young patients.
And what about the gender split?
A slight tilt toward women, 53% female, which is 32.6 million, versus 47% male at about 28.9 million.
Okay, so those are the groups whose lifetime cancer burden we're calculating.
And this brings us to what I think is the most fascinating part of this whole study.
The risk paradox.
Yes. We know, as a basic principle of radiation safety, that younger patients are more sensitive to radiation.
Absolutely. Their tissues are developing, cells are dividing faster, and they just have more time to live for a cancer to develop.
The risk per exam is unequivocally higher in the young, no question.
So you would think that kids, that small 4.2% of patients, would be responsible for a huge chunk of those 103,000 projected cancers.
That's the intuitive conclusion, yes. But the data tells a completely different story.
And the story is,
Despite that higher inherent risk, adults, that massive 95.8% group, accounted for the overwhelming majority of the total projected cancers.
How overwhelming are we talking?
We are talking about 91% of the total.
91%.
That's about 93,000 of the 103,000 projected cancers, all coming from the adult population.
Wow. That is genuinely surprising. It really forces you to think differently about where the problem lies.
It does. In public health terms, sheer volume trumps biological sensitivity.
So we might have been focusing a bit too much on pediatric safety and maybe overlooking the sheer number of scans being done on adults.
It's the utilization factor. Even if the risk per scan is lower for a 50-year-old than a 5-year-old, when you multiply that lower risk across 59 million adult patients,
The total just explodes.
it dominates. This finding really shifts the focus. It's not just about special pediatric protocols. It's about system-wide dose optimization for every single adult scan.
So if adults are driving 91% of the future cancer burden, which specific procedures are the biggest culprits?
It's dominated by a couple of key procedures. Number one, by a pretty significant margin, is the abdomen and pelvis CT.
Okay, walk us through the impact of that one.
The abdomen and pelvis scans are projected to cause 37,500 of the 103,000 total cancers.
That's over a third. 37% of the entire projection from one type of exam.
It's a staggering number, and it's tied directly to volume.
How many of those scans were there?
30 million examinations in 2023. It's the most frequent high-dose scan, and it covers so many critical organs: the colon, bladder, bone marrow.
Okay, so that's number one. What's number two?
Number two is the chest CT.
And the projection there.
Chest CTs are projected to cause about 21,500 cancers, or 21% of the total. That reflects about 20 million examinations.
So if you just combine those two, abdomen, pelvis, and chest, you're talking about almost 60% of the entire projected future cancer risk.
Well over half. It's an incredibly clear, actionable target for healthcare systems. If you can lower the dose on just those two procedures, you dramatically change this whole picture.
Let's move to the outcome itself, the cancer types. What are the specific cancers we're talking about?
Well, given that chest and abdomen scans are the drivers, the top findings make a lot of sense.
So I'm guessing lung cancer is high on the list.
And it's number one. The most common projected cancer is lung cancer, estimated at 22,400 cases, a direct consequence of all those chest CTs.
And what else makes the top four?
Following lung cancer, we see colon cancer projected at 8,700 cases, then leukemia at 7,900, and bladder cancer at 7,100 cases.
The leukemia one is interesting. That really points to the bone marrow exposure during those big body scans.
It does. It shows the systemic sensitivity. But there's another critical finding we have to talk about, especially for female patients.
You're referring to breast cancer, correct?
I am. While it's not in the overall top four, if you look only at the female patient population, breast cancer was the second most common projected cancer.
What's the number attached to that risk?
We're looking at 5,700 projected cases, specifically within that female patient group.
And that's because the breast tissue is so often in or near the primary beam for chest and upper abdomen scans.
Exactly. And it's highly radiosensitive, especially in younger women. So it's not just about overall dose, but also about careful shielding and collimation.
It highlights a specific anatomical vulnerability that translates into a really substantial number of future cancers.
Absolutely.
You mentioned earlier that the 103,000 number is robust. Did the researchers run any other models? What if BR7 is too conservative?
That's a great question, and yes, they did. They ran extensive sensitivity analyses, essentially tweaking the assumptions.
To make sure the finding wasn't just an artifact of one specific model.
Right. And across all those different analyses, the estimates remained uniformly large. They ranged from a low of about 80,000 projected cancers up to 127,000.
So the message is clear. No matter how you slice it, we're dealing with a verifiable 5-figure problem from a single year of medical practice.
The scale of the problem is substantial, regardless of minor statistical adjustments.
So what does this all mean for you, the listener? We've set the scale, 93 million exams. We have the core projection, 103,000 future cancers. We know who's at risk, adults, because of volume. But what's the critical so what here?
The big picture implication is it's a stark warning. The study calculated what happens if current practices just continue.
And that gets us to the 5% benchmark.
It does. The study projects that eventually CT-associated cancer could account for 5% of all new cancer diagnoses every single year.
5%. Let's just sit with that for a second. 5% is not statistical noise.
Not at all. It transforms this from a niche safety issue into a major quantifiable driver of future cancer incidents.
Right up there with other well-known risk factors.
It absolutely is. And the key thing here is that this is a modifiable risk. We have control over this factor.
This isn't about stopping CTs when they're needed.
Of course not. It's about realizing that our current average practices are creating a large and preventable future cancer burden. We have to maximize the diagnostic good while actively minimizing the dose.
Especially for those two big procedures.
Focused almost entirely on those two primary exam types.
Okay, let's do a quick recap to pull all these nuggets together for our listener.
Sounds good.
First, the sheer volume. 93 million exams in 1 year.
Second, the total projection, around 103,000 future cancers.
Third, and this is the big one, the role of utilization. Adults drive 91% of those cases simply because of volume.
And finally, the actionable targets. Abdomen, pelvis, and chest scans. Those lead primarily to projected lung, colon, and leukemia, and critically breast cancer in women.
It's a phenomenal look at the true cost benefit of this technology. We've seen that CT is a known carcinogen and that high utilization among adults is driving these massive projections.
The medical need is often undeniable, but the data is a clear challenge to just business as usual. The practices we accept today will absolutely dictate the cancer statistics of the next generation.
Which leaves us with a final provocative thought for you to chew on. If we accept the projection that 5% of all future cancer diagnoses could be linked back to today's CT scans, how quickly must medical institutions respond?
What combination of automated dose tracking, mandatory protocol reviews, or even new non-radiation technologies would be needed to fundamentally shift that 5% projection downward?
It demands a systemic solution, not just individual choices.
One that integrates this public health awareness into daily clinical decisions.
Food for thought indeed. Thanks for joining us for the deep dive. We hope this knowledge serves you well.
We'll see you next time.